This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. It's nice to see all the interventionalists in the room. But welcome, everyone. Today we have a special speaker. Dr. Brilakis is with us today. He's a professor of medicine at UT Southwestern and is really one of the experts in the world on CTOs. Dr. Brilakis originally did his training in Greece, came to the U.S. and did some residency fellowship at Mayo, and was originally on faculty there before moving to UT Southwestern, where he has moved through the ranks and is now a professor. Dr. Brilakis, as I indicated, is really one of the experts in CTOs, but also has a much broader expertise and is highly published within interventional cardiology, and his CV is quite heavy with numerous publications on a variety of things related to interventional cardiology, outcome studies with various technologies, as well as comparisons of radial versus other approaches for catheterization. But as I said, he's probably best known for his work on CTOs, and he's going to tell us what's missing and I guess the future. So welcome. It's good to have you here.
Thank you. Thanks, Dr. Taylor. Okay, it's a great pleasure to be here with so many good friends in the audience and discussing about the status of CTO PCI, which is interesting because when I started doing this, this was considered to be a niche area. People consider the CTO operators kind of crazy, and they still do to some extent, but I think things have really moved quite a bit in the last few years. These are my disclosures. Another disclosure is that I actually, as a CTO operator, I have a bias about the value of CTO PCI, which is a good thing, because imagine if the operator didn't believe in the value of what you do, then that's a problem. So I think the audience is very well versed with what a CTO is. It's 100% occlusion. It's been there for 3 months or more. And it's something they're going to see in your practice. This is from Canada. This is from the Pfeffer publication, the largest group, more than 10,000 patients. And essentially, 1 in about 8 patients is going to have a CTO, 1 in 5 if you take those with CAD. So you're going to see it a lot. If you happen to be in a VA hospital and you have a great VA here, 1 in 3 is going to have it. And if you have bypass in the past, pretty much everyone is going to have it. So it's something, it's not uncommon. It's a very common finding when you go for angiography. And normally the way you start this conversation is, why do we do it? And then how you do it. But here I'll start the other way around, is how you do it, and then go on to why. Because one of the paradoxes in the field is, if you can get the artery open, which wasn't the case always until the last few years, then how are you going to realize the potential benefit? So this is one of the early meta-analysis we did a few years ago, 18,000 patients, 65 studies, and that was the status of the field as of a few years ago, with about 77% success and 3% complication rate. And the really bad complications, death, emergency bypass, stroke, tamponade requiring pericardiocentesis are fairly low numbers, overall about 3% complication rate. And on the positive side, the success was increasing over time and the complication rates were coming down. So this was a good sign that at least we're moving on the right track, but this success was not exactly as high as we would like it to be. And this was done with 3 major techniques, and that's a little technical, but just for a brief introduction, one way to get through is to go from the front, that's the undergrade wires. The other is to go from the back end, go through a collateral vessel, and then go retrograde and try to cross. That's called the retrograde approach. And the third way is what's called the undergrade dissection reentry, in which you go intentionally outside the vessel and create some form of dissecting technique through the loose tissue outside the lumen, and then be able to get back into the true lumen. And this was our early experience. About 7-8 years ago, several groups started getting together in the CTO arena and try to learn from each other, and eventually, a few years ago, put together a combined experience showing that over a year, this is up to 2011, so this is these are the early days of the procedure. As you can see, over time, success rate went up from the 70s up to the 90%, and that happened with an increased use of the retrograde approach. So new techniques helped out. And then around this 2010 period is when the bridge point system, the dissection reentry came through, were part of the original trial. And you can see that over time, success went up with use of various crossing techniques. And then about 4 or 5 years ago, the group got together and decided, how do we put together these different techniques? When do you use strategy A, when strategy B, when strategy G? And that's when this so-called hybrid CTO algorithm came through, which starts from looking at the lesion, and then after looking at the lesion, you decide on 4 characteristics: where does it start, where does it end, how long is it, do you have collateral branches to go back? Based on those, then you decide your initial strategy. But at the core of this is the very bottom, the switch strategy, that if the first thing you do doesn't work, do something else. And that seems straightforward and easy to think now, but back then, the idea was if something didn't work, you stopped, patient went home, came back, and then you did the procedure. So that was inefficient, less success, and more trouble for the patient. This is a registry called Progress CTO we put together a few years ago. Now has 23 centers, and is growing about 1,500 patients right now. This is a paper just published a few months ago with the first 1,000 procedures. And you can see now success is up to 90%. It was 91%. The major complication rates were 1.7%. And interestingly enough, it was achieved by using different techniques. So you need all 3 strategies if you're going to get to this high level of the high success rate, with the eventual being successful in 40% for undergrade and about a third each for retrograde and undergrade dissection reentry. And this is true both for the more complex groups. For example, bypass patients are much more complex. They have much more calcium. They are much harder to recanalize. And in spite of that, we're now at 90% success, even in this group of patients that, again, were very challenging in the past. Same thing for in-stent restenosis, close to 90% success rate. If you don't like your guest CTO operator, you give them a CTO on the circumflex, because that's the one that has the lower success rate for various reasons, including tortuosity and lack of good interventional collaterals. And if you're Cal Alasvad or Stefan Frey, you can do it using the radial approach, although we actively discourage most people doing radial for CTOs, but in the right hands and people who are very, very experienced, you can get the same 90+% success rate using a biradial or a radial femoral approach. And this is the data from OpenCTO, which is another registry that just got presented about a couple of weeks ago at TCT. 1,000 consecutive patients, 12 experienced sites in the United States, with the similar profile of high BMI, high diabetes prevalence, about a third of the patients having previous bypass. And what was found is very similar to Progress. In success rate was 89%, and efficiency was decent with about 2 hours procedure time, 2.5 gray for air kerma radiation exposure, and 265 mLs of contrast. And there was a little high complication rate in terms of early and 30-day mortality, about 1.3%, related in large part to epicardial collaterals and retrograde recanalization. But overall, so high success, good efficiency, as I'll show you in a few minutes, good improvement in quality of life, and encouraging things for being able to recanalize those lesions. Now, Progress and Open are the experienced centers in the US, but this is what actually is really happening in the real world out there. This is from NCDR, published earlier this year. Actually, Dr. King published it, so we appreciate that. And the reality is that in real life, success rate is much, much less. It's 59%. So you don't realize this 90% success rate, but you have a much lower success rate, and the complication rate is 1.6 versus 0.8. It's double than that of non-CTO PCI. And complications are higher across the board, much more urgent coronary bypass, much more risk for tamponade, much risk for high risk of a myocardial infarction. So clearly, we are not there yet in terms of the overpopulation of patients, and efficiency is not there as you would expect, more contrast and more radiation you need. So the title of the talk was, what is missing in CTO PCI? And one of the things that's missing, a very important one, is that yes, experienced operators can do this with a high success rate, but if you look at the general population of interventionalists out there, success is still lagging behind, and what can we do to achieve consistently good results among different centers and different operators? And there are different ways that we can get there. One is selecting the right people for the right job. education, of course, getting techniques standardized across the globe, and then having some new devices that can help us get there. This is a TED Talk from Richard St. John. It's highly recommended. It's 3.5 minutes, and he goes through 8 secrets to get success, and that's not in CTO, obviously, but I think it applies quite nicely to CTO as well. And the very first thing he puts there is passion. I think it's very true for CTO. If you're going to do this, you have to love it, because it's going to be sometimes, quite often, challenging. It's going to be stressful. So if you don't love it, then probably that's not the best thing to do. So do it only if you're convinced about it and if you really feel strong about it. But just being passionate is not enough. The second thing is put the work that's required, and that doesn't happen overnight. It took several years of practice to get there, and the 10,000-hour rule from Malcolm Gladwell definitely applies here as well. Do your homework in terms of studying and attend meetings. We have a webcast we've been doing for the last few years on complex interventions. The next is in a couple of weeks. And it's interesting, every time I do this or attend one of those, I always learn something. I think the beauty of the field is that you never know everything. There's always something new happening. You can always improve your practice and make it better. And of course, reading the journals is important, and Jack Intervention is highly supportive of CTOs, and he's been early on showing new techniques and outcomes with use of these procedures. Attending meetings is important. Tremendous growth in the last few years, which increases our frequent flyer miles, but also get people together to make things a little more standardized, and a lot of proctoring going on for sites who are starting to help people get there as well. And it's not just for CTO. I think, in my experience, being there and talking to other people, you learn better, but also, even if they don't do CTOs in the end, just this cross-pollination, talking to people, different tips and tricks, can help you get everything, not just CTOs, done well. And one of the challenges right now is that there are not enough people to go around to do this proctoring. And can we do it in a different way? This just got published this week in JIC, showing that Google Glass had, at least in a not online and offline fashion, it was actually good enough in interpreting basic angiographic findings. Now, I don't think we're there yet in terms of the fine detail you need for doing remote CTO PCI proctoring, but we're getting there. There's a company we're working with called Vital Medicals, which is pioneering this, having you do everything wirelessly and without having to touch anything, just tilting your head. You can zoom in, zoom out, and communicate, and that's where I think this is going to go in the future. Another thing is paying attention on the basics. Last week, I was in a lab, and they were refusing to do 2 guides. They were refusing. They said, we don't need it, and everything else. Finally, after half an hour, they agreed. And after they did the case, they were like, wow, why aren't we doing this before? So there's some basic rules of the game. The basic one is use 2 guides almost always. The second one is to go with a wire and a microcatheter. This may sound very simple to you and very obvious, but believe me, out there, many people don't believe in those, and until you embrace those, your success will not be there. And then, of course, having the things you need. Equipment can be heavy sometimes, but having everything in one place in the lab can really help you get this done. And having a good fellow or a good technician who can keep things organized is critical, because with 20 wires on the table, sometimes you cannot find what we're looking for. Another thing important for CTO and non-CTO is the attention it brings to radiation economy. You don't want to be wasting radiation. You want to do this with the least amount. So right now, we do every case, not just CTO, every single case in our lab at 7.5 frames. I actually get upset if I see the image being very clear, because it tells me there are 15. So always, make sure that I go in the low frame rate. Always use a rad pad, a radiation protection shield, to minimize our exposure. And I think by doing that and watching how much radiation we give in every patient, we haven't had any major burns like the ones you see here. A third thing for being successful is the focus. So if you're going to do CTOs and congenital and peripheral and structural, this is not going to happen. And especially in the beginning, you're going to focus on this and take the time and the energy you need to get good at it, and also the time you need for every case. You do need to spend the time, often up to half an hour, looking at the angiogram again and again and again. You'll be amazed at how many things you pick up at the minute 25 after you're looking at the same film for 25 minutes. It's been a revelation for me how much more you can learn and be more focused on the film. Having an outline, the hybrid algorithm is also nice. And having ideas is very important. This has been our kind of outline, how we learned to do CTOs. The 2004-7 was the early years, essentially when TCT saw retrograde, came back, started doing retrograde. Bad idea. Don't do it. It was extremely, at the time there was no other option, but obviously now it's different, but a lot of stress. The cases we did then, we look at them now, we're laughing, like what we're thinking, but it worked. 2007, 2010 is when the Bridgepoint system came through, get more proficient on retrograde, started the undergrad dissection reentry, and the last 5 years, we kind of had all the tools of the armamentarium. We had the dissection reentry tools, the retrograde tools, the undergrad tools, and every single, people tell me, why do you publish case reports? And I tell them, that's extremely exciting to me because I learn more in a case report sometimes than in a big data paper. So I believe just discovering as the need arises and sharing that has been very, very nice. And we keep on, interestingly enough, I think CTO has become one of the major areas of publication in our lab, with close to 100 papers, I think, as of the last few months. So it's just learning every day and getting new ideas and implementing them and continuing the cycle. That's been a lot of satisfactory for us and other places. The learning curve is real, and it takes time, as mentioned before. This is what happened in the initial 3 centers. As you see over time, success rose up to more than 90. At the same time, the use of contrast and fluoroscopy went down. Like everything else, the more you do, the better you're going to get. No question about that. And the same is true for NCDR. So even in the NCDR registry, overall success was not very high, but if you look at the high volume operators, which weren't that many back then, the more cases you do, the more your success, the lower your complication rates. So practice makes perfect. Unlike most PCIs we do, CTO PCI is going to fail. You're guaranteed. Even in the best centers in the world, you're going to have failures. And this can be a problem because many interventionalists have a strong ego. And failing is not something you want to do. But it's part of the game, and there are different ways to do it. You can fail and be miserable and bitter, and this can happen, or you can fail and learn from it and try to get better. Our approach has been, whatever disaster we have, we publish it. So I get phone calls from my colleagues like, what were you thinking? But it's a redemption, and also we learn the lesson better, and I think other people may learn the lesson as well without having to go through the process of the failure and the complications that sometimes go with it. And last, but not least, is you do it for a reason. You obviously have to do it in patients which indicate the benefit, and that will be what we'll discuss in the second part of the talk. But can we make this easier? Yes, there's all these 8 steps, but can we make it simpler? Are there some things we can do to increase our success and complication rates? And one of them is predict what's going to be tough and what not. And yes, you can get a feeling of how tough it's going to be. But what we know is that there's some scores like the JCTO or Japan CTO score, and the higher the score, from 0 to 5, the higher the score, your success goes down, and you are much more likely to need in red and green, this is the dissection reentry and retrograde. So using that score, you can get a preliminary feeling of how bad or how difficult is the CTO going to be. Similar thing, we've just developed a score called the Progress CTO, more aligned to the components of the hybrid approach. But the point being, you can get an assessment from the angiogram as to how likely you are to open that CTO or not. Can we make it similar approaches around the world? And CTO remains a relatively polarized area, with Japan having different opinions and Europe having different opinions and US having different opinions, but things are slowly converging. This is from TCT again, from Dr. Tsuchikani, one of the Japanese leaders in CTO, and this is the Asian Pacific CTO algorithm, and it's actually very gratifying to see that we're converging now. They have similar things, the proximal cap ambiguity, do you have collaterals, do you have good quality distal vessel, and then going down that pathway, selecting your crossing strategy. So a lot of synergy right now with Japan. Europe, from the EuroCTO Club a few weeks ago, We still have some way to go, but things are moving, and I think for the people who are learning especially, it's very nice to have a common, unified approach rather than everyone doing their things their own way. Now, what is the usual fate of the new CTO devices? Not very good. So most CTO devices have not done well. This was a safe cross many years. When I was training as a fellow, this was there. Endless hours, red, green, and we never figured it out. That was the front runner, blunt microdissection catheter. Very promising, made some spectacular perforations, never worked out really well. Although the periphery is still used, but for the coronary, not anymore. But there's been some successful devices. This is one of them. This is the Gaia guide wires. These are made in Japan, and they are a special construction called composite core that if you turn it on the back end, it transmits fairly well to the front end. And you never get to believe those things until you actually use them in cases where nothing else works. And that was the same thing we had. That was a case, Lima, supplying a PDA, an RCA CTO. That is a case that had failed 3 times in an outside hospital and was sent to us. And we had only retrograde option. You could see it coming down the Lima and then to the collateral, going up the RCA, through the stent. And no wire would go. None of the regular wires would go up because you had to go down the spiral of the Lima, through the collateral, all the way to the eye. By the time the wire made it here, nothing would move, except for the Gaia wires. So it's cases like this that make you understand and be convinced that these wires can be useful in getting that artery open. So these wires have definitely made a big impact. We're still learning how to use them, but we're seeing a lot of improvement over time. The bridge point system, the Crossbows and Stingray had also been some of those devices. Fairly useful, although we still don't quite understand for the Crossbows exactly when to use it. We just launched last month a trial called the Crossbows First, trying to see if we use this device first instead of guide wires, is that going to make our procedures more efficient and faster than if we start with guide wires alone. Again, there's 12 sites worldwide, and we hope to hear the results by next year at TCT. This is the other device called the Stingray, in which is a flat balloon with 2 exit ports, which has been a very important device. When the wire goes out of the lumen, you want to get back in, this one can really help you get back in with high success, more efficiency, and avoiding causing a lot of dissections. New devices are coming out. This is the Prodigy. Rich Heuser put this together. It's a microcatheter with a balloon around that can give you support. So good idea. We're still seeing how it works in real life. Same thing for the Roxwood devices called Center Cross and Multicross. This is a microcatheter with a nitinol mesh around it. This is the same thing with 3 lumens. And what this does is anchors you to the vessel, gives you a lot of great support to be able to push through and recanalize the occlusion. And this is the same thing, so you can get your microcatheter through and cross. And there's another device called the Nova Cross, which is in Israel, not in the US yet, but same idea. So the new devices now all have the same principle, give you extra support, but in my mind, what we need is actually devices for the entry. The Stingray is good, but could be much easier and faster and safer, and having a device that works on that end would be extremely useful, and we're still early stages of developing one, but this is a thing where the need is more so than the support. So what is missing, number 2, is to have new devices that can take the technique, maybe not all of them, but at least some CTOs make them faster and more efficient and more successful for the average interventionalist. How about the quality of life? What are we doing this for? And I think this is the main reason why we do CTO PCI.
For the last 3 years, before I got the surgery from you guys, it was heavy. But I mean, I thought it was just something that it was just a part of what was happening to me, because I knew that I had heart problems, and I knew that I had bypass surgery, and I knew I had stents in my heart. So I just didn't know what the results from that would be. That procedure was, to me, a lifesaver. Before I had the procedure, well, I guess I was at about my 8th year of having the bypass. My 8th year, I couldn't even put out the trash. I couldn't take a real good walk without taking a glycerin pill. But like I said, after having this last procedure that you guys gave me, I can put out the trash, cut the yard, and relax. And take it easy without really worrying about anything so forth. And like I said, I do appreciate that procedure. That was one thing that I did in my life that I think helped me out a whole lot. And it's still helping me out.
So he wasn't coached. There was no script. This is what he felt. And there are many people like him who are told for many, many years that, look, there's nothing we can do for you. You had bypass, you have severe disease, nothing can be done. And then you recanalize them, and they feel a whole lot better. So the number one reason for doing this is to improve symptoms, improve angina. There are other benefits in terms of LV function, reducing LCS, maybe arrhythmia control. In the VA, a big component has been improving quality of life in terms of being able to take Viagra. And that's important. Actually, our pharmacy used to force everyone to take a stress test before they gave Viagra, and that becomes a huge referral source for interventional cardiology because everyone was positive. But anyway, we told them this makes no sense, so they stopped doing that. But also, in terms of the physician, apart from helping patients, you improve your skills. And this is one of the few areas right now where there is growth in terms of PCI volume. The best data right now for quality of life comes from Open CTO, again, fresh off the press from TCT, showing a significant improvement in angina. This is 1,000 patients with Seattle angina questionnaires at baseline and at 1 month. And you can see significant improvement in all components, frequency, limitation, and quality of life. And the same thing for dyspnea. Dyspnea improves, a measure of depression goes down. So there is a significant improvement. Now, having said that, these are uncontrolled observations. As I'll show you, we believe we should have a formally done sham-controlled trial to compare CTO PCI with medical therapy. But again, this is not done as of yet. Most of the stuff presented so far is papers comparing successful versus failed CTO PCI. And although that's useful, it has many limitations because you don't know if the difference is because of the benefit of success or because of harm from failure. This is the largest meta-analysis. King just published it a few months ago, and showing that across the board, more than 50 or more % reduction in mortality, MACE, myocardial infarction, regardless of how you defined CTO or what subgroup you looked at. Another potential benefit, although not realized yet, is that of the impact of CTOs on subsequent ACS. So if you have a CTO in red and you are unfortunate enough to develop an ACS, then you have 3 or 4 times higher mortality than if you don't have a CTO. Now, that doesn't mean that if you have a CTO, you will get an ACS, but if you do, you're worse off than if you did not. And that's a double jeopardy idea. And in meta-analysis, obviously, if you had a CTO and an ACS, you had 3 to 4 times higher risk for subsequent complications. Why is that? Maybe part of the reason is that when you have a CTO, one artery is out, then the ACS take out another artery, and you're not left with much perfusion to your myocardium. And we do know complete revascularization does improve outcomes. This is from Santiago Garcia from Minneapolis a few years ago, showing that complete revascularization, either with PCI or with coronary bypass, can reduce mortality. This is from Tim Mixon, showing in some patients, not very many, but there are several out there. There are several definitely out there. They come in with uncontrolled arrhythmias, recurrent ICD shocks, and they get revascularized, and in their CTO, and arrhythmias improve. So occasionally there's patients like this. And a common issue with this, people are saying, well, there's so many CTOs out there, how can you open them? As you told us, 59% success, most people don't do CTOs. That's true, but for specific patients, they can make a huge difference, like the veteran I showed you, and the patient I showed you with the VT. And you may know the story from the circus. So this was a baby elephant. He came to the circus, so they tied his leg into the pole, and he couldn't move. And then since then, he grew, and now he's a huge elephant. And this is nothing. I mean, he just moved, he would just take it with him. But because he's been so conditioned to it, he doesn't try anymore. And this is the growth mindset. Carol Dweck's framework principle applies a lot to PCI as well. I think there are things you can do, and I think you could do many more. And sometimes we get hung up on the past and not move in the future. But the reality is there are many more things you can do with PCI right now. And CTO is just one of them. I mean, structural obviously is a big part. MitraClip, Tower, I know you have a huge program over here. But there are many areas, CTO PCI being one of them, that can be the next step and help intervention grow more and more. And it's not just for the CTO. This is an example. We're doing right coronary. Then we crossed, balloon, dissection, put a stent, and sure enough, the guide comes out and the wire comes out. The patient, it's acute vessel closure, ST elevation. Now, it's kind of embarrassing, call the surgeon to bail you out from a dissection of the right, but you have to do something. So, took a pilot 200, knuckle technique, went around. This was such a nice big vessel. Re-entry was very quick. Stingray catheter, two dots, got back in the distal vessel. The vessel was open, got the stent, patient is doing fine. So converted a kind of embarrassing complication into a salvaged case without any major problems. So having the techniques and the skills that CTO PCI teaches you can help you bail out in procedures like this. And it can also provide benefits for the institution. There's the so-called halo effect, which means that if you see something in a positive light, then you tend to see that person or that institution overall in a positive light. And CTO PCI is one of those things that if you do good CTO PCI, you are viewed as a good PCI in everything, left mains, bifurcations, everything else. And that halo effect is a good thing and promotes the institution's reputation and referrals. I used to have this slide about what CTO PCI has been proven to achieve in right randomized controlled trials, and the answer was right here. But as of last week, for TCT, the first trial actually of CTO PCI versus medical therapy was presented. That was by Jose Enriquez in TCT, called the Explore trial. It took about 8 years to complete, so it was not easy. And he randomized patients who had a STEMI and were found to have a CTO in a non-culprit lesion to either undergo CTO PCI or medical therapy alone. And then he brought them back at 4 months. They did an MRI and saw what was the ejection fraction and the LV and diastolic volume. And what he found, to our disappointment, is that there was no difference in ejection fraction and there was no difference in LV and diastolic volume. So in spite of recanalizing the CTO, there was no significant difference in the primary endpoint. There was an interaction. If you did it in the LAD CTO, then you did have an improvement in EF. But if you didn't, if it was the RCA or the CIRC, you actually had harm, so those were balancing each other together. But one limitation here is that success was 72%. So the question I have, and the paper is not out yet, but is what happens in those 72% of the patients? Did you see much success or not? Because if in 30% you don't have success, that's one of the potential limitations. We don't know yet, but clearly it's a critical study. It's the first one of its kind. It took a long time to complete, and it's the things we need to go down the line. And although this is speculative, I think we need many more studies like this that can provide some randomized control data on the benefits or not of CTO PCI. And that's what's missing, number 3. We need more randomized control trials. Yes, we can say observational studies registers, but at the end of the day, randomized trial is the gold standard. What do the guidelines say? The ACC guidelines give a class 2A indication, and it's phrased very carefully, very artfully, I should say. It's that you can do PCI of a CTO in patients with appropriate clinical indications and suitable anatomy when performed by operators with appropriate expertise, which is a very politically savvy statement, but it means, in my mind, that if the patient needs it, and if you can do it, that you do it. But that's a little more guidance we need than that. And the same thing in the European guidelines, class 2A, level of evidence B. And although we do say, yes, we do need randomized controlled trials, this is cited as the main limitation of CTO PCI, and to counterbalance this is from Jack a few months ago, who took a look at all the guidelines from 8 years, from 2008 until 2014, and saw how many recommendations were based on level of evidence A, which is the randomized control trials, and it was about 11%. So although yes, we'd like to have RCT data, the reality is you make most of your decisions using inferior quality data. So yes, we need more, but it's not every field in cardiology that has the quality of data needed to make the strong recommendations. Are there any studies right now going on in this particular area that can be useful? There are. This is from Korea. Dr. Park is running the Decision CTO trial, planning to enroll 1,200 patients, and with a primary clinical endpoint, death, MI, stroke, and any revascularization. The problem is, apparently, enrollment has been very, very slow. So the study was supposed to finish 2018, maybe a few more years. And the second one was from Gerald Werner from Europe, called the EuroCTO trial. Same thing, 1,200 patients, and trying to look at primary clinical endpoint. But the problem is they ran out of funding. So we're going to have only 500 patients in this. So the power will be compromised, obviously, and that will be another major limitation. So there are these big trials, and we're having a hard time completing them. But not everyone is the same with the CTO. There are some patients, the ones with single vessel right coronary CTO, for example, or the ones with previous coronary bypass, that are you going to improve their survival by opening the RCA CTO? I don't think so. So there are some people who are going to do this not for survival benefit or reduction in MI, obviously, based on CARS, unlikely to be there, but you're going to do this to improve symptoms. And that's, I think, one of the type of trials that needs to be done. It's just definitively prove, like renal denervation versus sham control, are you going to have benefit or not? And the other one are the patients with multivessel disease that they need PCI instead of bypass. And then these are the ones you may have also improvement potentially in hard endpoints versus symptoms alone. So we do need a randomized trial for CTO PCI. We can do it because success rates are up there. And sure enough, payers will be asking for it. And it's part of the natural evolution. We're now at the stage where you have enough groups, enough operators, enough hospitals doing this at a high level that we can test it in a more formally fashion. And it's important for this to continue to develop and provide results. And this is one potential study design we've been trying to get funded for the last several months. I think we're finally about to get started now, probably the next couple of months, which is called the SIGN CTO trial, looking at a small pilot. It's going to be only a couple centers, and randomize patients to CTO PCI versus sham control, and then see if the quality of life is improved based on objective measures, Seattle-Edna questionnaire, and cardiopulmonary exercise testing. So things like this are needed more and more before we launch the mega trial to look at the hard clinical endpoints. So to summarize, CTOs are common. You're going to see them in 1 in 5 patients in your practice. You can recanalyze them in high success in experienced centers, but we still need to translate those outcomes to less experienced sites and operators to make it more widely available for patients. And finally, although we do believe, most of us doing this procedure, and I think many other people do believe that you can provide significant clinical benefit, it is time now to prove it without doubt through some appropriate randomized clinical trials like the EXPLORE trial I just showed you. And I think for me, CTO PCI is a journey. When I started working on this, I never expected this to be a big part of my practice or my research practice for that matter. But it's been a tremendous experience, both in terms of growing clinically, but as of research, it's one area where people are not excited about publishing as much. I think most operators are very busy, don't have enough time, but also it's been rapidly developing, leaving a lot of opportunities for academic endeavors. But as Kavafi said, many Greeks you have in the audience, that when you start on the way to Ithaca, you wish that the way belonged, full of adventure and full of knowledge. So it's not about getting there. It's not a destination, but it's actually to enjoy the journey. It's about learning through the journey and making every day count. And it's been a tremendous journey for me. And again, every day I learn. And every day, I think, can make a difference. And we have a long way to go, but that's the beauty of it. It's not a destination, it's the journey to getting there. So thank you very much.
Thanks, Manos. That was fantastic. I'll start off with a question, and I'll just warn everybody here, we're down to one microphone. Oh, no, we have two? Maybe they're both working. We'll see. But remind everybody to use the microphones. And our remote folks, if you can use the chat window to put in your questions. But I'll start with one. So I was talking to a colleague over the weekend about the same sort of issues about selection of patients for CTOs and matching operators with complexity. One strategy that the valve guys use is they spend a lot of time planning and have a team that looks over every case. Do you think that's where we are, at least for maybe those that have the higher complexity scores or something like that? Would that strategy help us to better select patients, to minimize complications and enhance success?
No, I think you're absolutely right. I think the heart team approach applies to structural, applies to coronary. CTO is just a subgroup of coronary. It's not a field of its own in reality. It's just a part of the CTO. So, like every vascularization decision, I think the best way to do this is through a heart team. Now, many of the patients we're doing, about 40% or so, are previous bypass. So, in general, the surgeons are less excited about going back in and doing a second procedure. Many other patients are not surgical candidates. Many have single vessel RCA CTO, for example. So, but you're absolutely right. There are many patients with complex disease that have CTO as well that are best served with bypass. No question. You have diabetes, you have two CTOs and a middle AD and good targets. This is the patients who go for bypass based on freedom and everything else. So, in my mind, the CTO part comes in after the patient has been deemed that he needs PCI. And he's not a surgical candidate. If he's a surgical candidate, I think that's the way to go if you can for many of those multi-vessel disease patients. The issue in many places is not knowing what is feasible. What ends up happening is those patients go for medical therapy. And that's, I think, what at least the complex PCI group tries to avoid is if you believe the patient needs revascularization and it can be feasible in some settings, then we should pursue that rather than just let them go on medical therapy for long periods of time.
Great talk. On this topic, always I have the question if you use imaging for ischemia as a factor to decide who you will open or not, because I know symptoms can be very subjective. Do you use more information before you decide if you will open the vessel or not?
Sure. Yeah, that's a great point. That's a great point Dr. Brilakis brings up, which is the issue of stress testing and ischemia. And I would say it depends. So if you have a patient, for example, who has a single vessel CTO, classic angina, and no other potential culprit, do I need a stress test? Probably not. But there are many patients who don't have classic symptoms. They have some dyspnea in the setting of COPD or pulmonary disease, and you're not sure, okay, is it the heart, is it the lungs, what exactly is going on? I think for these patients, it's very important to have a stress test. And actually, Aaron Grantham has shown that CTO PCI gives you benefit if you have a large area of ischemia, more than 12.5 or 10%, depending on who you talk to. But you're absolutely right. When you are not sure if you have the real symptoms, then I think it's very, very important to do a stress test. Another area where it's important is when you are trying to, you have multi-vessel disease and you're not sure that, which part is which, or is the segment, the CTO viable. There was an MRI study showing that like almost 80%, there was some degree of myocardial damage in the area of the CTO. So if you're not sure if it's viable, then you need something, PET CT or whatever is the local standard, to make sure it's viable before you canalize, to make sure you do, work in the area that needs to be worked versus not.
Well, it was a great talk. Thank you. I've heard talks on CTOs given by multiple people, but that was really a nice sort of overview of where we are and where we need to go, which is what's important. So with respect to where we need to go, let me ask you a question. If in terms of designing a trial, right? So sort of the options we have are to focus on sort of the low end single vessel disease patients and concentrate on quality of life versus take patients with multi-vessel disease in CTOs, perhaps non-diabetics, like for instance in the FAME-3 trial, right? It's a multi-vessel physiology versus bypass trial, but then have a CTO component to that. So now you're taking the higher risk ischemic burden patients and randomizing them. Potentially more bang for your buck, but more complicated because you might be revascularizing multiple territories. So where do you think we should put our next focus? You think we should have a nice, crisp, clean study and single vessel CTOs and concentrate on angina and quality of life? Or we should take the more complex patients and think about complete percutaneous versus surgical revascularization?
It's a great talk, and I mean, a great question, and I agree with you that that area is very tough. My vote is start with the low-hanging fruit. I mean, we have, the big studies, what happened. So the Euro failed. I mean, the resources you need to do a study like this are so big that it's hard to achieve them in this current environment. So the Euro CTO is not working. The decision is lagging behind. So to run a big trial like this, 10, 15, 20 million, whatever it takes, probably more than that, it's going to be tough. So my approach is let's start what we can do with more resources, get some success there, and we can expand it as well. So based on the science, my approach is let's start with the symptoms first, definitively prove it, and then move on to the more aggressive targets.
That was terrific. You mentioned that many of the operators are too busy to publish, but you're clearly not in that group, and I congratulate you for all your great work. And also, it's your assertion that not everybody needs to get in this. It's really a pain in the neck, and you got to really work at it. Is reminiscent of another guy that said this about balloon angioplasty about 40 years ago, Andreas Grunzig, who said, this is a good way to sort it out. But the idea of randomized trials here is fascinating. I mean, this sham trial, I'm lost to how on the earth you could do that. But anyway, you can tell us about it. But they're so different. All these patients are so different that, you can show this guy, severely symptomatic, can't do anything. The whole situation is one where you can't help him, and then you point out that you can only help him if you know how to do it, and you got a track record for doing it. So I'm wondering. I mean, I don't know any randomized trials, for instance, with plastic surgeons to do facelifts and say, we'll randomize all these people to a facelift or not. I mean, the field grows based on what you demonstrate. I don't know. It's part of your question, but I'm not sure you can just do a across the board thing and end up with an answer that opening CTO is good, opening CTO is not good. I'm pessimistic we'll ever get there, but maybe find some subsets you can do.
No, I agree. I think you got an excellent point, and that's why I think this group. I think that the criticism we get is there's a big placebo control. You open the CTO PCI, right, and then you do the CTO, and then okay, people feel better. But this is because they think. I don't believe it. I agree with you. I think it's what we do, but so many people don't.
Yeah. So with the sham, if you do a sham, maybe to your point, I mean, you could identify them with a CT or something. And know that you've got it, and then you say to the patient, okay, this non-invasive test, we saw that you have this total occlusion. We either treat it medically or we take you in and we stick things in you. And then maybe you could get people to and then said, if we do it, we're gonna either do it or we're gonna do a cath, and when we're not gonna do anything. It sounds like a hard sell, but maybe one way to start that would be to identify them non-invasively.
Great talk and a great book. Your book is really great. So the CT evaluation of chronic occlusion, there have been a lot of papers on it. If you see a chunk of calcium, those are not approachable, at least in my mind, they're not. What are your thoughts on that?
That's a great point. So Japan and Europe loves it. They do a lot of CTs. They say you can plan the procedure, understand where you're going. My opinion is that the only place I see for it in the current environment, experienced operators, is when you don't see a distal vessel. There are some times where you have very diffusely diseased distal vessel, you don't see it, then CT would be a great way to make sure you're not missing collateral somewhere you're not seeing, something like that. But my question is, if you can get 90% success without doing it, and I'm not sure, because they say they co-register, but here in the US we don't have this co-registration. We can get the CT images and put them on the angio and then be able to tell, okay, I'm going the right direction or not. And I haven't done it obviously, so I cannot be assertive about it, but my gestalt is that probably doesn't help you very much, and we don't do it very often, except for those cases where you don't see a distal target vessel and you want to make sure it exists before you try this.
You have a remote question, which I bet you I know the answer. What will lower the failure rates, Stan? I guess he's looking for the main thing. Is it operator experience? Is that the...
Well, I guess... you're right. The bottom line is, if it doesn't work, then the current environment is send it to someone who can, to another more experienced center that can recanalize them. Now, some cases still will fail. 10% will fail still, even in the best hands. But as you say, it's just, if it doesn't work, try to more experienced centers. Where it gets a little tricky is that the more you push the success rate, the risk-benefit ratio changes a little bit. Where people have tried and failed, and you start pushing the envelope, you go this complex retrograde, going through limas, then your risk goes up. So you always this balance, how far you're willing to push to get this high success rate versus say, okay, we know what, the safety is paramount. And that's, I don't think anyone has a good grasp of it, but I think you can safely get it up to, upper 80s, low 90s, but beyond that, it starts getting the risk-benefit ratio might start tipping off, so I wouldn't be pushing too hard to get the 100% success. I think that you're going to kill some people in the way to get there.
All right. Well, thanks so much for a fantastic talk. That was really, really great. Thank you.
The preceding program is copyrighted by Emory University.